Welcome back to the 7th video in the course Health Technology Assessment, and this is a summary lecture. This lecture will give an overview of all the previous videos which you have been seeing. And that's basically we're going to look at, what is HTA, the costing, the outcomes, how to synthesize results, and also to look at the methods for economic evaluation. First, let's go back. Why do we need health technology assessment? Why do we need economic evaluations? I think it's clear that in general we don't have enough resources to meet all society's needs, and that means that we have unlimited and scarce resources and unlimited needs. And that only doesn't refer to money, but it also refers, for instance, to staff or to devices. So we always have to struggle with our needs, which we have in healthcare, and the available resources. And that means that we have to decide where we're going to devote our money, our staff, etc. to. And if we want to do that, we have to have information also about the economic aspects. So the decisions about resource allocations have to be made. And we want to do that in a sensitive way, in the way that we maximize health with limited resources. And that means that we have to have information about also the economic impact of an intervention and the economic impact of a disease. And that's where HTA comes in, because HTA is the discipline which informs decision makings about improving health while also looking at efficiency. We also talked in the first lectures a bit about the terminology. There are a lot of terms which we also use throughout the videos. And if we start with the broad concept, that's health technology assessment. Health technology assessment is a broad multidisciplinary field which includes, for instance, epidemiology, cost effectiveness, but also ethical aspects and judicial aspects, and which informs policymakers, for instance, the Ministry of Health, whether we should invest or whether we should implement a certain intervention in one country, for instance, the Netherlands. So HTA collects the information from a number of disciplines, synthesize them, and then informs policymakers or about a go or no go or questions about a new intervention. A part of HTA is economic evaluation. In an economic evaluation, we're looking at a new intervention and compare that to an existing intervention, or mostly to care as usual, in terms of cost and effects. And it's a part and pillar of HTA, and that's the part where we balance cost versus outcomes. Within economic evaluation, we have a specific form which is called pharmacoeconomics, and that basically refers if you're doing an economic evaluation focusing on drugs interventions, so on pharmacological interventions. And in the media, we often see terms like cost effectiveness and cost utilities. And these are wrong synonyms for economic evaluations, which are used in the media, but they're actually specific forms of economic evaluation, and I will come to them back a bit later. So if you look at the terminology, it basically goes from health technology assessment, economic evaluation, to specific forms like cost effectiveness, cost utilities, and pharmacoeconomics if we talk about pharmacological interventions. And this is a slide which you also saw a lot. If we're looking at a full economic evaluation, what we always do is that we look at a new intervention, compare that with an old situation, and that's the care as usual. And what we do in an economic evaluation is that we look at the difference in cost, and we do that from a societal perspective. So that means that we're not only looking at the intervention cost, but we're also including healthcare cost, patient and family costs, and costs in other sectors, for instance, productivity losses or educational costs or criminal justice costs. And what we also do is that we look at the effects, and that's also what we normally would do in an effectiveness study. But where we differ is that we include the effects not only in clinical outcomes, but we also include the effects in terms of quality adjusted life years. And at the end of the analysis, we built a relationship between the difference in costs between the new intervention and the care as usual, and the difference in effects between the new intervention and the care as usual. And we built a relationship between those two, mostly by using a ratio. There are different ways of doing an economic evaluation. An economic evaluation looks at the costs and effects always of a new intervention compared to an old intervention, but there are two ways of doing that. One is that you do an economic evaluation alongside a trial. So you already have a randomized control trial or other trial, and in that trial you include instruments to measure resource use, to measure the difference in societal cost, and you include an instrument to measure the quality of life, like the EuroQol, to be able to assess the difference in quality. And if you do that, if you do a trial and you take along these instruments, then you're doing a trial-based economic evaluation. We could also build a model. We could have a decision tree or build a Markov model, and where we synthesize all the evidence which is around in the literature and basically have a kind of calculation model in which we calculate the difference again between the new intervention and the care as usual. And what you will see in practice is that often there is a combination of a trial-based economic evaluation, which looks at the short-term effects, and we combine that with a model-based economic evaluation where we look at the lifetime effects of an intervention, and this combination gives you the best insight to the policymaker whether they should invest in the new intervention or not. We also distinguish several different forms of economic evaluations. We talked about the cost minimization analysis, the cost effectiveness analysis, the cost utility analysis, and the cost benefit analysis. Well, if you look at these different forms, we see that if we look at the costing side, they all do the same. So they all measure the cost, the societal cost in euros in our country, and compare the societal cost of the new intervention to the societal cost of the care as usual and subtract them. So this part is the same for each of the types of interventions. They distinguish in the way that they look at outcomes. We have the cost minimization analysis, and in the cost minimization analysis, you assume that the outcomes, or you know that the outcomes, or you measure that the outcomes are identical between the new intervention and the care as usual. This has some drawbacks because there's always uncertainty, of course, surrounding the effectiveness. So what you will see is that in practice, the cost effectiveness and the cost utility analysis are used frequently. In the cost effectiveness analysis, we measure the outcomes in natural units, and natural units is a different term for clinical outcomes, descriptive outcomes, quality of life satisfaction. So basically the outcomes which you normally would use as a healthcare professional. If you relate the cost to the outcomes which you normally would use as a healthcare professional, we're talking about cost effectiveness analysis. In a cost utility analysis, we measure the outcomes in utilities or quality adjusted life year, and we do that because quality adjusted life years is a synthesis about both survival as well as the quality of life or the utility of the population. And it's a generic measure, so that measure can be used in all diseases and all interventions. So for policymakers, this is very informative because they can compare interventions in the field of heart disease to interventions in the field of general practice, to interventions in the field of mental health. because it's a generic outcome which we can use in any disease and any intervention, it's also more easy to understand what is the gain of a certain intervention. And then we have the cost-benefit analysis. And in the cost-benefit analysis, we express the outcomes in monetary terms. And you can imagine that this is quite difficult to do, that it's quite difficult to express outcomes like survival or how people are feeling in monetary terms. So basically, these two are less used. We prefer to have a cost-utility analysis, so we find it quite important to include the generic outcomes because that combines both the quantity and the quality. So you always will see a cost-utility analysis in the guidelines, for instance, in the Netherlands, that the government asks for a cost-utility analysis. And we often combine that with a cost-effectiveness analysis. Because a cost-effectiveness analysis, if you already do a trial, you already measure the clinical outcomes. So you often see in particular cases a combination of cost-utility and cost-effectiveness analysis. So if we look at, now we go into separate parts of the economic evaluation. So we have the costing part as well as the outcome part. If we look at the cost-effective, what's relevant to realize that the perspective is quite important, and we mostly will do an economic evaluation from a societal perspective. And that means that you have to look at the health problem, see what's relevant for the health problem, and include that in your measurement. Because we look at the costs from a societal perspective, so we're not only looking at how much an intervention, new intervention is costing and how much the existing intervention is costing, but we're also looking at the impact which the intervention has on the society. We include different type of costs. So next to the intervention costs, we look at healthcare sector costs, patient and family costs, and costs in other sectors. And optimal is a societal perspective. In several countries, that's the guideline. That's what you should do. In some countries, you also will see that people ask for the healthcare perspective. But overall, optimal is a societal perspective, because then you can also see what is happening outside the healthcare sector and whether there's not a cost shift from the healthcare sector, for instance, to patient and family costs. If, for instance, a patient would leave the hospital quite soon, that could mean that you save costs in healthcare, but maybe there is much more informal care needed, so you have much more patient and family costs. So optimal is a societal perspective. What we will do in a trial-based economic evaluation is that we measure resource use. We have different instruments for that. If you want to have more information, you can look at the earlier videos. And there are two ways of measuring cost. One is to look at incidence-based, to follow new cases and measure their cost. And the other is prevalence-based, to look at all cases, new ones and old ones, and measure their cost. And you can do also the cost measurement top-down. And top-down means that you use literature or statistics to gather all the information. And that's often done in a model-based economic evaluation, or bottom-up by using a resource use instrument. And that's often done in a trial-based economic evaluation. So the final step next to identification measurement is valuation. And that's basically translating the resource use in prices. In the Netherlands, we have a costing tool for that. So there's a standard guideline of how much a GP costs, how much one hospital day costs. There are standard costs for that, so you can use the reference prices. And if we look at productivity losses, there are two ways of doing that. In general, if we look at productivity losses, we're looking at the days out of work, and we multiply the days out of work by salary. If we do that from the moment something occurs until retirement, we use the human capital approach. If we do that for a more limited period, we use the friction cost method, because you could say after a certain period a person is replaced, so it's not fair to include all the costs until retirement. In the Dutch guidelines, the friction cost is the standard method, but in other countries, other methods are standards. And of course, we always have to look at discounting, so differences in time and how that relates to cost, and also inflation. That's also important to have a look at that. Now we go to the other part of the economic evaluation, and that's the outcome side. And in the outcome side, you basically can distinguish also the 3 steps. So this would be the identification, where we here say we have to measure health-related quality of life, we have to measure it, and we have to value that, and we value that by using utilities. Well, as a summary, we said we're very much interested in health-related quality of life because we want to include the multidimensional aspects of quality of life. We want to see the whole dimension of quality of life, and we want to see that from the perspective of a patient. So we want to use patient-reported outcomes. And as we mentioned, health-related quality of life is increasingly used in clinical research, but it's actually in standard if you look at economic evaluations. Well, if we look at the measurement, we saw that you can use generic measures. That are measures which you can use in any disease or any interventions, or disease-specific measures, which you, for instance, only can use in cardiology. Preferred in a cost-utility analysis, you would use a generic outcome, like the EuroQol. And for a cost-effectiveness analysis, you can use a disease-specific measures. And we also looked at the different types of generic measures, that you have preference-based and non-preference-based. And that basically means that in a non-preference-based, you get a kind of health profile, which gives a description of the health state, and in a preference-based, the respondents themselves, so the participants in the trial, will give a value to the health states, which varies between 0 and 1, where 1 is perfect health and 0 is death. And for a cost-utility analysis, you need a preference-based health states valuation. And you need that because in the long run, you want to calculate the QALY, the quality adjusted life years, which is a combination of survival combined with how people feel, how their quality of life is. And for that valuation, you need the health profiles, and in most countries we have national or social tariff to go from how people fill in the questionnaires to this number from 1 to 0 and sometimes below 0. So these are the steps. If you look at outcomes, we focus on health-related quality of life next to the clinical effectiveness. We measure that by generic preference-based instruments in order to have a valuation set to come to the QALY. We also talked a bit that there are basically 2 methods for economic evaluations. One was the trial-based, where I talked a bit about already. And the other is that we also can make a more quantitative approach using decision trees, using Markov models, or a combination of both to look at the evidence which is available. And this is, for instance, a decision tree. So here you have a decision, should I do the new intervention or not? And for both, you have the side effects or no side effects, and attached to that, you have the costs and the qualities. And the evidence from this you will get from the literature or other sources. Another way of doing that is a Markov model. In a Markov model, you have potential events, and each event has certain costs or qualities, and there's a likelihood transition from several health status. So a simple Markov model will have 3 health states: healthy, disease, and death. And attached to that are transition probabilities, and attached to each disease event or healthy or death are certain costs and qualities. Again, this information you will get from sources which are already available, for instance, national statistics or the literature. And then you have a kind of calculation model to calculate the cost effectiveness of an intervention. When we have the cost and the outcomes, it's also important to synthesize them. And here we have the new intervention, and here we have the control intervention, and how we relate them to each other is that we take the cost of the new intervention, CN, cost of the new intervention, then subtract the cost of the control interventions, for instance, care as usual, so minus CN, and divide them by the QALYs of the new intervention, QALYs N, and subtract the QALYs of the control interventions, QALYs C. And then you get an incremental cost-utility ratio in this case, because we're looking at utilities, or if these are clinical outcomes, you get an incremental cost-effectiveness ratio. And this ratio is a number like, let's say, 20,000 per QALY or 25,000 per QALY, so you get a certain outcome, how much it will cost for the society in order to gain 1 QALY. And what can you do with that measure? You can plot it, you can draw it on such a cost-effectiveness plane. And for instance, if there are additional effects and additional costs, like 10,000 euros per QALY, it's in this quadrant and then it's cost-effective. But let's say it's 10,000 pounds per QALY. It's still hard if you know in this threshold what to decide upon that. And that's why we have certain thresholds. We have values which express how much a society is willing to pay for a certain outcome. And you can plot that in a line in such a cost-effectiveness plane. Everything below that line is acceptable because it's below the threshold, below the willingness to pay for a QALY in a certain country. And everything above that threshold is rejected. And this threshold is very important in these two situations, and not in these two situations. Because if you have a new intervention which is saving cost while adding effects, then we say it's dominant, then you should always implement the new interventions because we want interventions which are saving costs and adding effects. On the other side, if an intervention is more expensive to society and less effective, you would always reject it. So these are clear situations. In this quadrant, where you have more effect and more cost, and in this quadrant, where you have less effect and less cost, it's much more uncertain, and there we need this threshold, there we need this value, and if we know that it's below a certain value, from an economic point of view, you could say, well, this is cost effective, and if it's there, it's not cost effective. One of the most important things is if you do a trial-based economic evaluation or a model-based economic evaluation, you have to realize that there's always uncertainty surrounding everything which you measure. And that's why we always do a sensitivity analysis, and there are two types of sensitivity analysis which we discussed. The deterministic sensitivity analysis and the probabilistic sensitivity analysis. In the deterministic sensitivity analysis, you manually vary one parameter while keeping all the other parameters equal. And we also refer to that as a univariate sensitivity analysis, and you can show, the different influences of the different variations of one parameters. You can show that in a tornado diagram, and you saw some in the earlier lectures, but you will also see some in the application lectures. Another type of uncertainty is that there might be uncertainty about, the variation of the parameters and the distribution around the parameters, and for that you can do a Monte Carlo simulation, and then you get this cloud with a lot of plots, and then you could express things in a cost effectiveness acceptability curve, and a cost effectiveness acceptability curve is basically saying, if I would look at different thresholds of willingness to pay, what would be the likelihood that a new intervention is cost effective or not, and then you can visualize that. But for details, I refer to the other lectures where it's explained. Well, this is the summary lecture. Thank you again for listening, and we have a number of application lectures where we don't go in detail in the theory, but we look at the application of all the theory in the field of cardiovascular diseases. I would advise you to listen to that, and thank you very much for your attention. Thank you.